I'll be the MC. My name's Shane, and I'll be the MC for the next few weeks. And our lecturers are Doctors Mohamed, Khalifa and Vasu, Sood, both from CHS, who I will do a full introduction on shortly. As I said, the webinars will all be held at 7 o'clock Australian Eastern Standard Time, which is Sydney time. If you miss it, the recordings will be there, as I said, from Monday. We encourage you to answer questions. Obviously, everybody's got the hang of the chat because they've been telling us that they can't hear anything. Thank you for that. I'm very red-faced, although you can't see it at the moment. Usually there's some really experienced people there who can add to the chat and really give some extra insights over and above what we teach as well. For those of you who have never taken part in any of our short courses, first of all, an extra special welcome to you. This is a first for us, a joint course delivered by our cousin organisation, ECA College of Health Sciences, and it's to a combined audience from both ECA, CHS and ITM. Both of our organisations create and deliver master's courses, CHS in health management and IT masters in IT specialisations and business. The idea behind the courses is simple and several-fold. We offer them so that you can experience what our teaching style and content is like at a master's level. You can get some practice in and pre-learning, as many of them run parallel, are part of, or extend some of our subjects. For example, this one takes some material from HM005 from the CHS Health Management Master. If you haven't studied for a while, it's a great way to ease back in. And also, it's also great to just learn something new. Obviously, we also sell our full master's courses, both to local and international students. And we hope that the best way to do that is to give some of it away for free. If we do a good job of that, which plainly I haven't done the first 5 minutes, then you may be encouraged to enroll in the full masters if you get something useful out of it and the time becomes right for you. With that said, we want this course to be a useful and rewarding exercise. We want you to learn, have some fun, maybe make some connections with fellow students. To date, there are over 1,200 people enrolled in this course, so remember to get busy in the forums. You will have also heard from Kit already. Kit is our administration technical support person. She will be doing the moderation in the chat, and she is right on top of everything. If you have any questions around that sort of stuff, send them to Kit in the chat. If you have questions for our lecturers, then you put them in the Q&A so they can get that as well. It is time and long past time to welcome Doctors Mohamed, Khalifa and Vasu, Sood. Mohamed is the Director of Studies at CHS and has a long history of both practice in hospitals and more recently as a researcher and the Chief Digital Officer at the Australian Digital Health Agency. So to be honest, I suspect he probably wrote some of the policies that he'll be explaining over the next couple of weeks. He's published over 50 research papers over the last few years, including a number on AI in health, and we will certainly be asking more about that at some point. Dr. Vasu Sood is a researcher and academic specialising in digital and mobile technologies in health. She has designed, taught and coordinated IT and health-related subjects and projects at several leading Australian institutions, including the University of Tasmania, Federation University, and ECA. In addition to her academic work, Dr. Sood has held leadership roles with the Health Informatics Society of Australia and the Australian College of Health Informatics, where she has supported innovation and collaboration within the health informatics community. As you will have gathered from that, we are dealing with some people who are real experts in the field tonight. Please make them both welcome. Mohamed and Vasu, I understand you're both going to teach this session. We have students from all over the world. Where are you on this balmy evening? Well, it's balmy in Melbourne anyway.
Yeah, thank you very much, Shane. My name is Mohamed, and I'm based in Sydney, Australia. And I have Vasu here with me as well. She's based in Brisbane, right?
That's right, Mohamed. Thanks.
Thank you very much.
We should probably have a quick look at our poll results before I get completely out of the way until the questions. Out of 168 responses, let's end the poll. We had 52 people from the health industry, 31%, 58% from IT, and 11% from neither industry. So it gives us a good idea of the sort of people who are coming along to these courses, and we're really happy to welcome you all there. I have shared the results. Let me know if that's getting in anybody's way and I can turn it off. But yes, I will hand it over to you, Mohamed, for the first module.
Thank you very much, Shane. Now, Vasu will start with the first topic of today's module. Today's module is 4 topics, 1.1 to 1.4. So Vasu will start the first topic.
Thank you, Mohammed. Welcome to Module 1, everyone. As Mohammed said, we will be covering 4 topics today in this module. So, topic 1 will be talking about Introduction to Health Informatics. And in topic 2 and 3, we will be focusing on health data as well as the data life cycle, which Dr. Mohammed will be covering. And then we will finish this module with topic 4, where we are going to understand the challenges in health informatics. So let's start with our first topic, that is health informatics. Can you move to next slide, Mohammed? Health informatics is made up of 2 words, that is health and informatics. This means there are 2 domains involved in health informatics, that is healthcare domain and IT, computing domain. If you look at this diagram, even in the IT, we can further divide into 2 subcategories, that is information science and computer science. So information science is where we are considering very simple information communication technology such as PDA or mobile devices. In computer science, we are considering more advanced concept of computer science. So they may be data analytics as well as machine learning. In addition, health informatics also incorporate human and organization behavior. Since healthcare professionals are the primary users of technology in healthcare domain, it is essential to consider how they interact with the technology, what are the factors which influence their interaction with the technology, and how technology is adopted as well as implemented in healthcare settings. Moving to the next slide, please. Therefore, if we summarize the meaning of health informatics, we can say health informatics is the science and practice around information in health that leads to informed and assisted healthcare. Informed means having the right information available at the right time in a useful format, so it can be used to make good decisions. For example, if a doctor is about to prescribe medication, having instant access to a patient allergy history and previous prescription can help avoid mistakes and ensure safe care. We talk about assisted using technology. It can help healthcare worker to practice easier and more safer support in healthcare domain. If we think about any example, for example, using a mobile application, if a patient is using a mobile application which is reminding patient to take their medication on time, then we can say that it is supporting them in following their treatment plan. So it is helping, it is assisting. Moving to the next slide, please. If we think about what is the scope of health informatics cover a wide range of areas that support better healthcare through technology and information management. If we look at this slide, according to International Medical Informatics Association, the scope of health informatics is somewhere where we are talking about technology, methodology, how the data is collected, how it is managed, how it is handled, and how it is processed, as well as various other domains, various other areas such as medication, health and biosciences, health system organization, and obviously we cannot forget computer science and informatics. Moving to the next slide, if we are thinking about the career in health informatics, we can consider the career in medical informatics, in clinical informatics, etc. As they are already shown, I don't need to read them. So if we talk about, for example, let's say medical informatics, what is that? What we will be doing? What is happening in medical informatics? So basically, medical informatics focus on the usage of information system in medical practice and research. If we talk about clinical informatics support doctors and other clinicians with tools for example, for diagnosis, for treatment, and for patient care. I will take you through the nursing informatics example later as it will appear again in our slide. So we will move to the next one, please. If we think about why we are talking about health informatics, what is the driving factors? What is the driving force? So driving force behind health informatics is global trend. And in global trend, for example, increase the efficiency of healthcare. So with the help of technology in healthcare, we can achieve this objective. Therefore, it is important to have technology in healthcare. For example, if we talk about increasing the efficiency of healthcare, a hospital uses an let's say a hospital uses an automated appointment scheduling system that can send reminders to patients and reschedules if they have missed any appointment that can be rescheduled. So this can reduce staff workload and waiting time for the patient. So we can say that health informatics or bringing technology in healthcare is helping improving increasing the efficiency of healthcare. Likewise, if we talk about improving the healthcare quality, which can result or which can lead to better patient outcome and safety, we can think about more examples here. For example, let's say a doctor is using any AI based diagnostic tools to detect diseases like cancer. Earlier, by analyzing the imaging, the x-rays, the CT scans, they can analyze them more accurately, which can lead to faster and safer treatment. So we have many benefits if we are using technology in healthcare. Moving to the next one, please. Yeah, we can say that the health informatics is playing a major role according to World Health Organization. Valid and reliable health information is fundamental to developing effective health policies and program, and health informatics or technology is helping in that area. Going further, thinking about what are the usage where this health informatics leading us, what is the benefits it is bringing. So it can bring many benefits. There are many uses of health informatics. For example, monitoring trends in the healthcare of the community. Let's say if health organization can use surveillance system to monitor trends of diseases such as heart disease, obesity within a specific community, or if health institution can collect national data on health conditions, and that can be further analyzed, which can shape public health strategies, so which can help to somewhere which can also help to understand the well-being, health and well-being of the people in the community. Moving further, please. We have now talked a lot of information and where we are saying that health informatics can bring many advantages. There are many usage of health informatics, but we cannot ignore the problems as well. Most common problem in health informatics are, for example, insufficient usage of available data. We have a large amount of data getting collected. We have, for example, data getting collected with the help of sensors. We have surveillance system as well. Now, all that data can bring some insightful information, but that is not there yet. We have not explored the full potential of health informatics yet. If we talk about other common problem with health informatics, it could be inadequate quality, for example, in decision making. So we can think, if we are talking about health informatics, let's say somebody is using electronic health record and healthcare professionals are entering the data there, or if some healthcare professionals are not entering the data correctly, or if they are entering the data a bit late, then there may be opportunities, there may be when we are talking about data analysis, the data which is getting collected in electronic health system, based on that data, if healthcare domain is making decision, then the quality of those decisions may be somewhere compromised if wrong data is entered there. Moving further, this is just a little bit information which is somewhere making you familiar about, if you are looking for your career in health informatics, or you're already working in health informatics, or looking for certain kind of certifications. As Shane mentioned, we have some kind of courses running here in ECA as well. So basically, when we are looking for the knowledge and skill in health informatics, we need the knowledge in the area of IT. What are the various IT applications, for example, how they are operated, and we obviously need to have all the qualification and education in medical domain. So if we look at this slide, it says like we need to have all the information, the competencies, the skills in information and communication technology, in health domain, in management, leadership, and health and social context. So basically, we need all those skills which can help to utilize technology in healthcare, as well as we need those leadership and management skills. Moving further, this is the topic I did not cover earlier regarding nursing informatics. This is one of the career, or I would say the area you may think about if you are interested or looking for going into informatics, health informatician. In nursing informatics, what will be the role of nursing informatics, and what qualification and skills they are needed. So we are a little bit aware now through this previous slide that the skills needed in both area, in medical and in IT. If we talk about the roles and responsibilities which healthcare professionals, for example, nursing informatics will be taking, they will be supporting the patient, they may be supporting the consumer, they may be participating in a decision making process. So if we say that how a day in nursing informatics will look like, it will be a kind of normal day, how the nurses work in the healthcare institution or in the hospital. So basically, we are saying that with the nursing knowledge, they also will be using technology, maybe participating in the decision making, going through the decision support system, looking at what the data is saying, looking at what insightful information can be extracted from the data, and maybe helping the senior manager, maybe helping the executive nurse to make much more informed and better decisions. Yeah, this is, I think, the last slide for topic one. Talking about nursing informatics position element. So basically, to go into nursing informatics, as I mentioned, you need to have the knowledge, skill, degree, let's say bachelor degree or master's degree in nursing, and the skills in the proper utilization of the technology. If somebody already working in nursing informatics, have experience in nursing informatics, they may be looking and targeting for more senior role, such as executive nursing informatics roles. With this, we done with our topic 1. Thank you. I will hand it over to Mohamed now.
Thank you very much, Vasu, for this nice topic. This is a really important introduction. I will now be presenting the second topic, which is about the sources and types of health data that we have in hospitals and different settings of healthcare. So the basic two main sources could be the institution-based and population-based data. When we collect data for purposes like diagnosis and management in hospitals, or for purposes, as you mentioned, Vasu, for surveillance and monitoring of different diseases. The next stage will be like data entry and storage, and then cleaning, and then data analysis, analytics and interpretation, and then presentation of that data to be produced as an information product. And then data can be used for strategic planning, as well as for operational activities, day-to-day activities, diagnosis of conditions, management of diseases, as well as statistics related to clinical outcomes, as well as the health system itself, like length of stay, average length of stay, bed turnover rates, all the different KPIs that we can develop when we provide healthcare services to different levels, primary, secondary, or tertiary. When we look at the sources of the data, we find that the data comes from all over the healthcare system, including hospital data like electronic medical records, pharmacy, prescriptions, lab results, radiology, consumer data, disease registries, claims, insurance, and even social media. So this what makes the health data very big, and almost big data, as we use to describe it, not only because it's big and diverse, but because it's coming from different sources in different formats. The sources of data could be national notifiable information, reports, mortality, morbidities, hospital records, lab, as we mentioned, even demographic data, animal and vector reports, for example, insects that transport certain diseases like mosquitoes and other insects. All of this data could give us good information about the trends of the conditions or infections, even absenteeism data, like where people are absent today or during this week. Is that because of a new wave of flu or COVID, for example, like we have witnessed over the last 5 years? The sources of mortality data comes mainly from vital statistics, such as birth, death, marriage, divorce, local state registries, notifiable surveillance systems, as well as hospital information systems and electronic health records. The sources of morbidity data could be coming from lab or, as we mentioned, radiology, cancer registries, adverse drug reaction data, injury, occupational accidents and illness data as well. And then to have good access to these different types of data sources, we need to consider the credibility of the data sources, the timeliness of the data, the methods that were used to collect the data, and then the target audience, and the purpose of the data collection and the data itself, including all types of limitations. So these 4 or 5 main, let's call them aspects of quality data should be considered. Timeliness, credibility, completeness, validity, reliability, and the method of collecting the data. Because if you have a data that is collected 3 months ago or 2 years ago, it's not really useful in certain conditions. the validity, the reliability, the accuracy of the data, all of these reflect how good or poor quality the data is. What methods do we use to collect health data? Usually we use routine surveillance systems. We could be using subjective questionnaires or even interviews. We could be using lab surveys, lab databases, medical examinations, history from electronic medical records, reviews from lab tests and results, epidemiological research, and outbreaks investigations. All of these are different types of data. Overall, we can classify the data into primary and secondary. Primary data means that this data was collected for this specific purpose of action. For example, we are collecting the data for diagnosis and treatment, so the data is now a primary data for that purpose. If a researcher came after a time and asked for the same data to do research, then this same data is considered secondary for the researcher. It is still the same data, but it is now secondary because it was not collected primarily to support research. It was collected primarily to support diagnosis and treatment. So this how we classify data into primary and secondary. And then why we do analyze the data, because we need to understand the trends of the data. We need to understand the trends of the conditions, infections, comparisons over time, populations, age groups, gender distribution of conditions, increase or decrease in trends. For example, effectiveness of specific health promotion, prevention, interventions, medications, comparing new medications to old medications, comparing different types of treatments so that we can understand the effectiveness of these interventions or compare the trends over time. For example, now we know that obesity and overweight is becoming one of the global issues and concerns worldwide, not only in Australia, but everywhere. So how do we know about that? Because we are monitoring the trends of obesity and overweight, trends of diabetes, trends of other chronic conditions, just like we did for COVID-19 in 2020. And for other chronic conditions as well, we can do the same. So we analyze the data to estimate the size of the problem, to determine the geographic distribution of the illness, to understand the natural history of the disease, detect any new epidemics, or generate even hypotheses to simulate and answer research questions, or evaluate control measures if they are effective or not, or monitor changes of the infectious agents, new outbreaks, new mutations of viruses, for example, changes in health practices, and to support planning as well. So we always need to understand the time, the person, the place of the condition. We need consistent numerator data, up-to-date population data, so that we can evaluate the problems, and well-defined disease characteristics and maps. We can use maps as well to understand the distribution of different conditions, including infectious and non-infectious or chronic conditions as well. Do we have limitations of these types of surveillance systems or data types? Yes. In certain countries, we could have underreporting because it depends on the severity of the disease. Sometimes the conditions are not properly or accurately reported because of underreporting. We could have also duplication. A clinician at a clinic might report a disease and the patient goes to the hospital, and then the hospital report the same case. So this creates more duplications, which needs to be cleaned before proper data analysis and analytics are applied. Variability of reporting, which includes variability of quality of data, accuracy of data, completeness. So all of these variability contributes to the process of importance of cleaning of the data before full analysis. We could have errors. Yes, we could have errors as well in transcribing the data. Generally, when we look at the types of the variables that we collect from statistical aspect, you can classify that into quantitative and qualitative. The quantitative could be classified into numeric, continuous, and discrete. Continuous variables, this is like purely statistics, but it's very important to understand it in the context of the health data. So continuous variables, just like body weight or body temperature, for example, when we have decimals and fractions. Discrete is more like independent, separate values, like the number of beds or number of patients. We don't have 1.7, 1.5. This could be applied to weight and height, but not to count of beds and patients and visits. So this is the difference between continuous and discrete. For the categorical data, they are not numerical, but they could be either nominal or ordinal. Mainly nominal means names of variables that cannot be classified ascendingly or descendingly. If you can classify them ascendingly or descendingly, then they are ordinal, not nominal. Like, for example, in university, at university, we use high distinction, credit, pass. So these are ordinal. But when you talk about colors, for example, yellow or black or white, this is nominal. So we need to understand the difference between these four types of variables: quantitative, continuous and discrete, categorical, ordinal, and nominal. We also need to understand the difference between the independent variables and the dependent variables, like X and Y. For example, Y depends on X. So X is the independent and Y is the dependent on X. So for example, height is the independent and body mass index is the dependent on height or dependent on weight. But not the other way around. We also need to keep in mind the correlation or relationship between exposure and outcome. We need to understand very carefully which of these factors is the exposure and which is the outcome. Like, for example, smoking and lung cancer, radiation and body cancer. So this is the exposure and this is the outcome, including the timeliness correlation, because every exposure needs time to produce the outcome. So this is how we design the research questions to understand the correlation between exposure and outcome. And this is why we need to understand the types of variables before we start collecting the data and analyzing them. So we need to understand the different types of data to define the magnitude of the health problems and provide the evidence, describe the natural history of the disease again, develop hypotheses and evaluate control programs and apply for new fundings. So overall, we can classify the data into population-based and institution-based. Institution-based is related mainly to healthcare organizations like hospitals, clinics, medical centers, radiology, lab, and so on. Population-based is more about census, disease surveillance systems, and population intervention. So these are the two main types of institution and population-based data. So this brings us to half of the webinar now, so we can have
probably a good time to have some questions.
Right,
so
right.
Please bung your questions in the Q&A.
Yeah.
Let's start from the beginning of some of them. Eduardo said, what's the specialization focused on medical devices, going back to the original list of specializations that you had?
Yeah, I can answer this question. So medical devices are usually integrated with other systems through either Internet of Things or interoperability standards, so that we can migrate the data from these medical devices into electronic medical records and hospital information systems. So most of these medical devices are under the biomedical engineering mainly. And most of the biomedical engineering, they have good understanding of the interfaces or the platforms that translate these two types of systems, from the software of these biomedical engineering or biomedical devices into the platform or the software of the electronic health record and hospital information systems. I think Vasu also can add some insights to answer this question.
Okay. Is there a good standard for how health data should be warehoused, i.e. relational database, a cube, flat files?
Vasu, would you like to answer that?
Yeah, when we are talking about the data, we in health informatics, we are using HIPAA compliance. So we make sure that the data is secure when it is transferred or when it is exchanged from one system to another system. So it should be both the devices should be talking with each other and when sharing the data with each other. So in other words, both the devices should be using the same protocol such as FHIR protocol or HL7 protocol so that the data can be transferred more securely.
Okay. I gather data entry into informatics is crucial to maximize its value and use, i.e. garbage in, garbage out. Is there standardization, e.g. ISO standards, etc., to ensure that data entry meets minimum requirements?
Well, in health informatics, we usually have validity checks that work to make sure the data is valid and reliable and accurate. For example, you can't technically enter a body temperature that is above 43 Celsius degrees or below 34 Celsius degrees because this is the normal body temperature range. For example, date of birth can never be in the future. Discharge date can never be before the admission date. So these are called validity checks. Some of them could check, for example, delta checks that make sure no big significant change is happening unless there is an explanation. For example, a patient with a body weight of 80 kilos cannot be 60 kilos in the evening or 120 in the evening unless there is something major happened. For example, an amputation, a major amputation operation was done for that patient of 80 kilos, and then the patient at night or the next day is 60. So these are different types. These are just examples, but we have so many of these validity checks that can help us to make sure that the data is accurate. You can look at the line graph showing the body temperature, showing the weight, showing the lab tests, comparing hemoglobin A1C, for example, from one test to the next or to the previous, to evaluate, for example, blood transfusion effectiveness, iron transfusion. So all of these can be implemented so that we make sure that if manual data entry was done, we avoid real significant change that cannot be explained. So the computer systems and the software and the guidelines and the range and the validity checks can help us to improve the quality of that type of data.
Right. How is data masking covered? Via different channels from different systems, or is this done when the data is at rest in the databases?
When we talk about data masking, when the data is getting shared, it should be, as I mentioned earlier. So basically, if I talk more into the technical field here, technical area here, there would be some kind of algorithms attached in the system. So when data is transferring from one system to another system, if somebody is sitting in the middle, for example, somebody is trying to hack the data, so there are some, even if they are hacking the data, they are stealing the packet, they may not be able to identify what the information is. For example, if we talk about asymmetric encryption, in asymmetric encryption, when data is transferring from one system to another system, let's say from sender to receiver, so they have some special keys which only those two systems will be sharing. So even in between, if somebody is entering, hacker is entering and trying to steal the data, they may not be able to encode the data. So those encoding and decoding keys will only be shared between those two systems. they won't be available publicly, so the data can be safely masked.
Okay, I've got probably a double question that we'll end this session on and then move into part two. But what are your thoughts on digital consumer medical devices, including smartwatches, phones, etc., as data sources, given that these aren't regulated and standardized?
Yeah, we are using various application. For example, in mobile devices, we have application in iPhone. We have health applications in Samsung devices, but these devices are not standardized. Standardized. These applications are not standardized, and the data which is getting collected in these application, that data is not connected. For example, that cannot be transferred to the electronic health record. So we can say that the data which we are collecting in our personal devices, that is where we can in future we can think about how that data can be connected with let's say with the electronic health record, so it can bring more values. Because for example, if I am tracking my sleeping pattern or my exercise pattern, that is really a very good tracking. But when I go to my GP, my data is not connected there. So whatever I will say, that they will enter there. I exercised for that many days, for half hour I did running, etc. But actually, the data is getting collected in my mobile through the application, and it is automatically, if I turn it on, it will automatically collect all those things. But that is where the gap in the health informatics, which we may be looking to improve in the future.
I think part two of that is a little bit like that. I was involved in projects in IoT with health devices, and the interesting thing that has struck me when you're talking about it is from a general health point of view, but when we were doing a commercial deployment, it was all about health insurance and money. And those data sets were going back to the physicians in theory, so the physicians could then, advise their patients. But primarily, the data is being collected so that the health insurance would pay for the devices. Is that something that's, is that a conflict for the industry between commercially available information, or do the health companies hold on to that?
I would just provide my personal view here. That is, I consider that is a lack between the commercial various watches and the devices and the application available, as well as healthcare domain. Because healthcare domain will believe on their own devices, which they have, like for example, they are getting ANSI approved devices, so they will be just the one which is getting used or which has been offered to them, for example, for the nurses to take and track and monitor the patient health data. So that is a gap in the consumerization of these application and the health domain. They are working, they are playing side by side, but they are not connected with each other. So if they can be there are the like areas where we can think and we can work on, where we can say that the personal devices information which is getting collected in our own devices, that can be, at the moment there is nothing like that. At the moment, whatever devices are available in the hospital, healthcare professional will trust on those one. They won't trust on any other applications or any other data coming from any other. If somebody is using their personal sensors or something, no, they won't trust on. For example, if they have to put the blood, if they have to track the blood pressure of a patient, the patient has to go to the hospital. They will put the Holter monitor and then will leave it connected with their body. So they won't believe if the patient is collecting data through their devices and putting all the reading there. So they will trust on their own device, but not on the devices which are so many available and applications so many available in the industry.
Great. We've still got a pile of questions, but I think we should move on, and we will get to more questions at the end as well.
Thank you.
Excellent. Thank you very much, Shane. So let me now do the third topic today, which is the health data life cycle. So when we look at the life cycle of the health data, the life cycle starts with planning and designing the systems that will be used to collect and store the data. And then we start collecting the data and creating the data. So some of the data are collected manually, such as history and physical examination of patients. Some are automatically collected, such as lab test results and radiology reports. They come from radiologists into the electronic health record system of the patients and so on. And the next is to analyze the data and start collaborating with this analysis between different departments and different services. Storing the data and managing the data as well is another step. And then we can evaluate and archive the data so that the data can be used for years and years. And nowadays we have data about almost all populations in some smaller population countries like Sweden and Norway, for example, compared to Australia, UK, or the US, because of a smaller population. So we have from birth to death of all of the population now, almost 100% in healthcare systems. And then the share and dissemination of the data through different types of reports and KPIs. Could be also through exchanging information or data exchange from one system to another, from one hospital to another, and so on. And we also have to plan for the access of information from different points and the reuse of the information for other services. So the main 8 key steps in developing high quality health information management services includes information plans that should be done, information systems that should be developed, standards adopted and implemented, systems well managed, routine reports developed and used, information and research should also be supported, training and skill transfer should happen effectively, and there are well-informed customers. So when we look at each of these 8 steps, ensuring that information service plans meet the needs of the client and these plans are completed before we start, as I mentioned, before we start collecting the data and storing the data, because we need the systems to be well designed and scalable for the amounts of data it will collect and it will keep and store over time and support the access of multiple users at the same time. We have been witnessing a lot of failures in electronic systems in hospitals when more and more users try to access these systems. And if we compare the systems we developed in 20 years ago to nowadays, we can find a different level of scalability because of the design of the systems. We need to ensure that the information systems meet our client needs, and these systems have been implemented. Our clients or users are internal users and external users. Internal users include clinicians and healthcare professionals and administrators of healthcare services. External users including patients, families, and health consumers and the general public. So these are the 2 main types of users for these systems. We need also standards that support the collection, the management, the analysis, and the release of information and exchange of information. And here in Australia, we have the national standards by the Quality Standards of Health Services. And we can look at each of these standards. Each standard is focused on a specific aspect like medication safety, clinical handover, blood and blood products, and prevention of harms like patient falls in hospitals, adverse events, drug-to-drug interactions, and so on. So all of these are different information standards that can help us to analyze, to manage, or to exchange information from one system to the other. The methodology to ensure information systems are appropriately managed, and as Vasu mentioned, the security, confidentiality, and privacy of these systems, so that no unauthorized access is happening, no, for example, hacking is happening, leakage of information, or loss of information. So all of these are methodology to keep these systems well managed. We need to ensure that we have good reporting, whether these reporting systems or tools are operational or strategic. Operational tools usually are in the form of dashboards showing real life, like active waiting time now in the emergency, how many patients are on the waiting list to be admitted, how many patients are now waiting to be transported to the operating room, patients due for discharge, number of patients in the emergency, number of patients in the outpatient now. So this is the dashboard concept. And the scorecard concept is the strategic use of this data or these indicators, comparing 1 month to another month, a quarter to another quarter, 1 year to the next or previous year. So these are the two main levels of dashboards and reporting scorecards. Developing experience relevant to timely preparation of health information and applied health research, which supports evidence-based practice. So our evidence-based practice is usually based on recently published research findings, systematic reviews, integrating research into clinical guidelines, clinical pathways, and informing physicians and nurses about best practice and evidence available for improving their practice. We also need training and skills transfer to the users of health information systems, because one of the major barriers of implementing health information systems could be human resistance because of lack of training, lack of skills. And usually doctors and nurses resist the change of implementing new systems when they don't have the skills or they don't receive the sufficient training on these new systems. So they get like threatened by the reduced productivity, especially at the beginning of implementing these systems, when they can't really cope with the complex interfaces or difficult routines or routines that take them out of their workflow context or stop them from doing their daily tasks or caring for their patients, when they spend more time on the system rather than communicating with their patients. We need also to ensure that we have good feedback, understanding the value and the perspectives and the expectations of the users, so that we can incorporate all of that into the design and redesign of these systems. Why do things go wrong? Because of multiple barriers or challenges facing implementing health information technology. Some of these barriers could be human related, as I mentioned, resistance of end users because of lack of trust or lack of training or lack of skills. Could be technical, the system is too complex, the system is too slow. It could be more related to organizational support. There is no organizational support from the hospitals for doctors and nurses and technologists to use these systems, or if there is no clear vision on the return on investment, how these systems are going to save lives, save money, save time, and so on. So we need a clear vision and strategy before we implement and start implementing these systems. We need to identify the project as a priority for the organization, and then we need the senior management to be engaged, completely engaged, develop the goals and benefits and the scope of the project, and develop and distribute the different guidelines on how to use the systems so that the systems can be effectively implemented. We need to answer the questions that everyone is asking about these systems when we implement or upgrade systems existing already in the hospital. Like, for example, what is the need for the system, for the new system, or for the upgrade of the system? In what stage of development is the system now? What parts of the system meets the needs of the organization and the needs of the users, and so on. So when we look at the system life cycle, we find that we start with analyzing requirements, planning, and then developing the system, or simply purchasing the system, and then testing, and then implementation or go live, where the system is implemented in different departments of the hospital, and then maintaining and operating the system, evaluating, and then returning back to analyze and learn from the feedback. So the stages, as we mentioned, starts with the requirements analysis, and then a good project plan to summarize, and then develop or purchase. We still need also to do some SWOT analysis, looking at what are the strengths and weaknesses, opportunities and threats of implementing a new system or upgrading the existing system. So we need to understand these 4 areas about the new system or the upgrade of the system. Now I will hand over back to Vasu to give us an overview of the last topic for today.
Thank you, Dr. Mohammed. We'll start and look at what are the challenges in health informatics. So if we can move to the next slide, please. If we look at this slide, it indicates that top challenges which healthcare CIOs are facing. For example, meaningful use of health information. Ensuring that digital health records are used effectively, not just filled out for compliance. So that is one of the challenge at the moment healthcare CIO facing. And then there are more challenges. For example, healthcare reform, because healthcare policies and laws are always constantly changing. So it bring another challenge if we say we have to use health informatics or we have to use technology in health domain. Then another challenge which has been indicated is mobile health and bring your own device. So that bring a security risk in health domain. For example, if a nurse's phone with patient data get lost or hacked by or stolen by someone, then hackers are pretty good and they can very easily guess the password. They have algorithm, they have tools, they can enter into the system log and can very easily intervene with the patient personal data. Another challenge is regarding the wireless networking. So if we talk about health informatics and providing, let's say, about telehealth, if a healthcare professional have to connect with a patient who is somewhere in remote or regional area, so network outage or weak signal may disrupt the care there, may bring challenges to connect or to have a smooth communication with the patient. Then we have so many challenges, for example, ICD-10. So ICD-10 is a kind of coding system which has been recommended by World Health Organization. I think now latest version they are using is ICD-11. That is the coding system, and it is a complex coding system. So the healthcare professional need training in it, because in that system there are like for each kind of for example, blood-borne diseases. So for each kind of diseases, there are a certain number or certain codes assigned. So healthcare professional need to be aware, may need the training here. That is one of another challenge. Moving to the IT challenges, as I think till now we were talking in the question answer session as well. If we talk about the technology, security, privacy, interoperability, so many challenges which we have already talked about. For example, if we say about security, protecting sensitive patient data from cyber threat is one of the challenge. For hospital may face a kind of cyber attack. Very common attack is ransomware attack that may lock down all the patient record, and the ransomware people may ask for some money to release the data, or if the hospital not provide, or if the organization will not provide money to them, they may be selling the data in the dark web, which can be further utilized for various purposes. If we talk about interoperability challenge, getting different health system and software connected, smooth transitioning of the data in interoperability, as Dr. Mohammed earlier mentioned that the various sources of data is coming from various sources. So all those systems from where the data is coming, they need to be connected with each other. They need to talk, they need to, when the data is getting shared. So that may bring the issue of interoperability if those devices are not following the same standard. Then with the technology, we another challenge which we can see in health informatics is big data and analytics. As huge amount of data is getting collected through various sensors, various monitoring devices, from through the wearable devices, which is not getting utilized and which is not getting analyzed. So that is also another challenge. Big data can also bring another challenge of storing the data. Maybe cloud may be one of the solution for that. If we talk about the fifth challenge, that is legacy system, that is a very common practice in IT. When they get 5-6 year old, we say that this technology is obsolete. So imagine if a healthcare facility is operating with a technology or with a software which is 10-year-old. Definitely they have to upgrade to the latest software and latest hardware. Now the problem with legacy system is they are not compatible with the latest software or the hardware. So in that case, it may bring another issue of putting more money and purchasing the new information system. Moving further, looking at what concerns, top healthcare concerns we may have going through health informatics or in general. One of the major challenge in health IT is reducing cost. Healthcare organizations must save money while they are still providing the services. So that is somewhere we can think about. If we are trying to bring the technology, it may help to reduce the cost various ways. Maybe providing assistance, maybe a remote monitoring the patient, maybe having telephonic conversation with the patient rather than having a face-to-face, which may be much more time consuming. So we can think about various ways of how we can reduce the cost in healthcare. Then we have talked about interoperability issues, securing data, as well as digital transformation. So what could be the major challenge with digital transformation? It could be one of the challenge could be, as I mentioned, legacy system when we have to upgrade to the new hardware and software. Another challenge could be some of the health facilities, maybe in some countries, maybe not in Australia, they are still working on paper-based system or outdated system. So they have not somewhere realized the full potential of health informatics so far. Moving further to the next slide. If we talk about the challenges, if we think of understanding the challenges of health informatics in general and challenges with using technology in healthcare. So technology brings its own type of challenges. For example, as we mentioned earlier, that systems are getting obsolete, so maybe need to put more money to bring new system. Or it is another kind of challenges. If we think from healthcare perspective, it can also bring the challenge for healthcare for healthcare professionals as well. Mohammed, can you please move to the next slide? Next, please. Thank you. So yeah, we are talking about health informatics. Now, healthcare professionals, their major objective is to look after the patient. They are more concerned about looking after a patient in emergency, that they are dealing with the life of a person. So using the technology, adopting the technology is not their primary objective. So it is somewhere a kind of, for some healthcare professional, they are reluctant to use the technology, or they may not be skilled to use that technology. There may be very various reasons behind that. Their main focus is looking after the person, not learning the new technology. So that may also bring a challenge. Moving to the next one, please. So yeah, we still have challenges to address. There could be many challenges. We have, as just summarizing, yeah, we can move to the next one. We have heaps of data, but that all data is not getting utilized. So we can say that we are data rich, but information poor. I will summarize this whole topic with my next slide. That is the IKW pyramid. This is a really a nice pyramid. I always love this pyramid. This is telling us what we can do with health data. So if we look at the pyramid at the base, we have data, and then moving to level 2, we have information. So data is something, the raw facts and figures. For example, a patient heart rate, temperature, body temperature, and blood pressure, that is all data, raw data. We know that these are the readings for heart rate, these are the reading for blood pressure, etc. Now, what we are going to do with that reading, in what context we are going to use. So when we provide a context to the data, that is called as information. So we may be structuring it in more better way. We may be organizing it. The example which I told you earlier, where we have patient reading, that is data. But if I say these are the part of patient vital signs, then we can say that is information. Moving to the third level in pyramid, that is knowledge. So if we have information available, then the knowledge can be extracted. For example, the nurse recognizes that the patient vital signs are normal based on the clinical guidance and the past experience. So now the nurse has gained the somewhere the knowledge. Moving to the top, where we are saying wisdom. So based on what data we have available, we can make future insightful decision that can help in decision making process. So if we have acquired the knowledge, we know if these are the readings coming for 100 patient, and if that is going to happen with a certain region of the patient, what is the future, what we can predict with the help of knowledge, or with the help of the basic data analytics we have done, how we can predict the future of the domain, or the future of healthcare professional. For example, if we have the reading of blood pressure for couple of patients, maybe 100 patient, maybe 200 patient, and we realized with the passage of time, after 2 years, 3 years, these patients started getting diabetes. So when we are dealing with a new patient, and if we see how the reading of that blood pressure reading for that patient is going on, then we may be able to predict. We can very easily predict from the past experiences, from the past knowledge. We can have wise decision. We may predict, okay, this is what going to happen with the patient, so you should follow this diet plan, you should follow this exercise plan, etc. I will pause my topic here. Thank you very much. Happy to take any question. Yeah, you can think about what tool you would like to include in your health informatics. That's all from my side. Thank you.
Okay, we've got a number of questions. Let's start here. What types of patient data are the most important to collect for improving electronic health record usability?
Well, I can answer this question. The main type of data could be, or the most important could be the diagnosis. When we have these symptoms and signs and history and physical examination, and then arrive to the diagnosis of the condition, all this is considered among the most important because this will build later on all of the other elements that we can use, like indicators of quality, indicators of diseases, conditions, and patterns as well. So let's start from the diagnosis. Yeah.
Okay. Tim says this is an obvious question, but as healthcare data involves extensive population information, is cybersecurity integral to every component across all systems, or is it a bit of a bolt-on later on?
I think Vasu can have a comment on that.
Sorry, Shane, can you please repeat the question?
Repeat the question.
Is cybersecurity integral to the design of healthcare stuff, or is it something that happens later on in piecemeal?
Oh, cybersecurity is the integral part in healthcare data, because if we are just designing or we are collecting the data, as Dr. Mohamed said, and if there are the data is not getting securely transferred, then what normally happen in cybersecurity, when, for example, we are talking with each other, so all the data is getting transferred from my system to your system, and everyone joined here. Now, this data is not just going from my system to another system. It will be transferring through the various path. We say they are the routers. So if hacker is sitting somewhere in any, maybe my data is transferring going through 100 routers. And if the hacker maybe sitting near my Wi-Fi, maybe very aware about how the data is transferring, what is the sequence of the packet, for example, 1 2 3 4, so they may attach, when the fifth packet of information is coming, let's say that is patient information, they may steal that packet, and in place of that packet they may add their own packet which may have malicious malware, let's say ransomware. So when the receiver is receiving that data, the malware will be entered in the system and will take the control of the system. A very simple example, for example, we are sharing email, and in the email we are having attachment. We normally share the attachment. So if a hacker is somewhere monitoring the data using various tools, Wireshark, etc., many tools available, and they can very easily hack the data. So cyber security is integral part when we are talking about health data. Obviously, that is the data of somebody's health, and it's the most precious thing for everyone. So we have to say that cyber security is playing the part and is the most. We can say when we collect the data, we say when the result will be disseminated. For example, when the data will be analyzed and result will be disseminated in the form of any publication, we say the data will be kept anonymized. But even if we say data can be anonymized, if we talk in technological term, there are the chances still data can be de-identifiable, because for example, if some event is going on and some data is entered about that event, so even though my name, if I have done the survey, even though my name is not there in the survey because that has been removed just to maintain that anonymity in the survey, but with the help of IT, if that is getting transferred, it is at least showing what time the data is transferred. So it can be very easily identified again. So we have to say, we must have to consider that cybersecurity is integral part in healthcare data, particularly healthcare domain is one of the biggest contributor of overall data. Maybe 30 to 37% of data is getting contributed by health domain. So we have to consider cybersecurity as one of the major part which can somewhere maintain security of the data.
Yes, and you can see where the crossover comes between IT Masters and CHS in this, because one of our biggest interest areas is cybersecurity. So it does interest a lot of the people here. There was a question around cost. What are the considerations given to the costs associated with digital health records and devices to access the information?
Well, the cost effectiveness of these technologies are not like of short term. The return on investment takes usually a longer term, like 3 to 5 years, to get a real benefit out of these systems in the form of reducing avoidable hospital admissions, unnecessary lab tests, improving flow of patients within the hospitals, reducing waiting time in emergency department, or reducing the number of visits in the emergency department by controlling better control of chronic conditions and implementing different technologies. So the costs associated with the implementation of electronic health records and hospital information systems can be gained again, like cost return on investment, but the return on investment is of longer term, not of short term. This is one of the things that makes the investment needs a clear vision and consistency rather than just waiting for like benefits and profits to be gained or collected over a few months after implementation. It's one of the challenges. Yeah.
Here's a question specifically for you, Dr. Mohamed.
Yes.
Has the HIS project team considered ISO 29585-2023 Health Informatics framework for healthcare and release data reporting? Enrico seems to know what he's talking about.
I'm not very familiar with this ISO standard. I'm not sure if it is a standard for quality of data or for data exchange. Because we have so many standards from everywhere, not just ISO. We have standards from the Technical Committee 215, so many standards. We have the HIPAA in the United States, the Health Information Portability and Accountability Act. We have the ICD 10, ICD 11, as Vasu mentioned. We have the DRG codes. We have so many of these standards. So actually, we might need a standard for the standards because they are becoming so many. So this is my knowledge in this area, but definitely we need these standards to be able to exchange the data effectively and achieve some kind of interoperability between different vendors, because not all hospitals in one country, even in Australia, not 100% of the hospitals, public hospitals, are running the same electronic health records. We have almost 5 or 6 major vendors selling these systems to public and private hospitals in Australia, and likewise in other countries as well.
It does seem rather odd that, you know, standards by definition aren't actually standard. Let's have a look. I expect the data storage for electronic health record is Google-based, e.g. Google, is cloud-based, e.g. Google, AWS, Azure, etc. Are there interoperability issues there when one health institution uses, e.g. Google, and another one uses AWS? And if so, is there a trend to move one to one of these exclusively? Or do they still build private networks? Does the government own it all?
We have some challenges in this specific area because, for example, here in Australia, we have a problem of storing health information on servers that physically lies outside Australia. So, for example, the Amazon servers, we had a problem with that. I remember in 2017, we were doing research at Macquarie University, and we could not host the data of research that was extracted from the public hospitals, from New South Wales Health, the Department of Health. We could not host that on Amazon servers because of this Australian regulation. Again, this could be different in UK or in the US, definitely, because Amazon servers physically lie, they are in the US, or 90% of them are inside the US. This could be different, but it's not owned by the government. The ownership should be primarily for the hospitals, but these servers should be secured through agreements between the government and the vendors and providers of the hosting services.
Right. Will having a data management policy help improve data quality?
Yeah, it should, definitely. Yeah.
We've got a couple of questions around how to get into health information or health informatics employment or manager jobs. Is this something that we'll cover later on in the course or maybe in the forums?
I think we can cover that later on in the course. But simply here in Australia, health information management, I think it is classified as health management. So I think if someone is inside Australia, they can look at the websites like seek.com, like LinkedIn, and look for health managers and health information managers in terms of jobs. And as we mentioned today, Vasu also mentioned one slide about the CHIA, the Certified Health Informatician Australasia, which is a certificate, professional certificate, not an academic program. It's a professional certificate that health professionals and IT professionals can take by attending a multiple choice exam and get certified from the Australian Institute of Digital Health. So this is one of the options, in addition to attending the courses like this one, in addition to the programs at the College of Health Sciences, and IT masters, of course, when they are interested. Yeah.
Okay. We'll probably just about end after this, but maybe one or two more questions. What are the requirements in Australia for health data retention? Or are we covering that again later on?
I think we are covering that later on, Vasu, maybe. But health data retention depends on the agreement between the organizations and the government in Australia, based on like 5 years or 10 years, based on the primary purpose of the data. For example, health data related to hospitals are different from health data related to research and universities. And some of them are linked to projects. And once the project is completed and finished, then data is either destroyed or completely dismissed from the servers. But for the health data, primary retention is like maybe 10 years for the things that are related to research, and maybe for life for healthcare provision, providing healthcare services.
Right. Okay, well, let's finish off with this. How do researchers use, or do researchers use does evidence-based research use the data generated in day-to-day practice by GPs, etc.?
Yeah, Vasu, go on.
Depending on the research topic and research type. So yeah, evidence-based data can be used. It all depends on the research topic. Regarding the data retention as well, when I was doing my PhD research, I collected the surveys from the hospital. So I had to keep them for 5 years safe. That was my responsibility. So after that, it was my responsibility to throw them in the bin so that nobody can get those surveys again. So just destroy them.
Right. I think with that, it's probably time to say thank you and good night. We do try and keep these sessions, to those who have been to, not been to one before, to about an hour and a half all up. But I would encourage everybody to go to learn.itmasters.edu.au, which Kit has been putting into the chat a few times, and engage in the discussion forums there, because there's been some good discussion starting to come towards the end, which as always happens. And I think there's lots that everybody has to contribute. I can see there are a lot of people from the health industry here who have got some really good things to add to the conversation. And there's some people from IT as well to talk about the technical side of things. So in closing, I would like to say a big thank you first to Kit, who is our indefatigable master of the moderation, and we'll be serving up all that information. If you have any questions about technical stuff, you can also email Kit at shortcourses@itmasters.edu.au, and we can get back to you on that with any problems with getting into the course. But of course, I really need to say thank you very much to Dr. Mohamed Khalifa and Dr. Vasu Sood for coming along tonight and giving this their time and their knowledge. And I'm really looking forward to next week.
Thank you, Shane.
Thank you very much, everyone. Thank you,
Thank
Shane.
you. And
you.
thanks for everybody for coming along. I hope you have a great weekend, and we will see you same bat time, same bat channel next week. Thank you. Good
Thank
night.
you.
Thank you.